Do you think the payers could start putting pressure on drugs, saying that you need to show MRD negativity in order to get clearance for reimbursement?
No, I think, again, if it's FDA approved and it's in the NCCN guidelines, we're likely going to do that. The interesting thing, we're likely going to cover that. I don't know that we would have any foot to stand on to say no. I think the very interesting question, and I know Mount Sinai is in this arrangement, and about another couple hundred practices around the country are in this Oncology Care Model with CMS and CMMI, where they're bearing financial risk for the total cost of care for these patients. And when the practice or the institution is bearing risk for the total cost of care, how is that influencing their decisions on what regimens to use? I know in our community where there's a practice of 25 oncologists who are bearing risk through OCM, and right now it's gain sharing only. If they beat the Medicare budget, they get to share part of that savings. They're looking at what you were talking about, Sundar, is decreasing the frequency from in relapse refractory patients from twice a week carfilzomib to once a week, or daratumumab containing regimens, and eliminating the other drugs and just going to daratumumab in those relapse refractory patients. So it will be very interesting in the future, especially if more and more practices and more institutions are bearing financial risk, to see how that risk translates into changes in treatment for their patients, especially on the back end when we get patients into MRD.
So does that, if I understand you correctly, is that model based on the fact that there is kind of a financial incentive on kind of holding back unnecessary resources?
Well, sure. It's not only on drugs, and it's probably the least on drugs. It's how do we avoid hospitalizations? How do we avoid ED visits? How do we use HOPA guidelines to optimize drug dosing in patients where the drug is based on body surface area or milligrams per kilo? So all those things are playing into how do we improve outcomes and reduce non-value-added care. And in this space, I would say, as we talked about earlier, if we're doing transplants in patients where we can't demonstrate the value of that, is that unnecessary or wasteful care? People don't like to use that term waste, but if it's not adding value or we can't demonstrate the value, it's probably a fair word to use.
So what would happen in this model if the patient says that I happen to know that there is a guideline that says I have the right to receive this, I want to do it? Would that be something that the institution would say no to? Or?
Well, you'd have to ask, you're the institutions, not me. but I think, but there's absolutely no incentive not to follow the evidence. I think when the evidence is unclear, that's where your clinical judgment, and Sundar, as you said, you're using your clinical judgment at 5 years to stop drug. I think physicians are being forced to think more critically about how they're treating patients, especially when there's not evidence that exists.
Yeah, I mean, from my institution, since you say we are one of the institution, I gather.
Yeah.
So it has not had any impact. The institution doesn't come or haven't had a meeting with us to come and say, hey guys, you are all in this, what do you call it, ACO?
OCM. Oncology Care Model.
Okay,
right.
Oncology Care Model, and that you should change your practice, etc. We are still evidence-based driven, even when we care for. That's one aspect of vigorously participating in clinical trials. So all the physicians are trained to clinical trial. So even the patients who are not eligible for clinical trial, we approach them in the similar fashion, and we provide them with the best of care. But I agree that we generally don't like bringing the patient to Mount Sinai emergency room, not because of anything. It's always overcrowded and our patients always complain. Yeah. So we have tried to avoid bringing them to the emergency room for that particular reason. And we've also started that we could provide them care in other ways, like 24/7 infusion center type visit where they can come and get some treatment or something like that. So we are looking at a different way, but at the bedside, as you said, we still practice evidence-based medicine, and there is no directive.
But are there any incentives built into the model that would benefit the program?
That's what I'm saying. We have not even had a visit from whoever the people who are contracting with the OCM come to us and said, we were just told it is observational, they are just capturing what we are doing, but they have not impacted on how we care for the patient.
So a simple way of kind of approaching it. So you're saying that the payers and the physicians are on the same page when it comes to the use of resources, based on what you are saying here. There's no
Yeah,
conflict.
I mean, the payers are, I do not know exactly where the payers, I mean, we still have third-party payers and all these kind of things. It's just the Medicare is in the
Yeah, well, just to be very clear, I mean, the OCM was set up as an experiment to understand whether or not putting physicians at risk and potentially sharing in savings could reduce the total cost of care for treating patients with cancer who are Medicare beneficiaries. And the hope is that we could drive out non-value-added care, the ER visits, the hospitalizations, end-of-life care, where patients might be better off in hospice than getting ongoing treatment. So that's the low-hanging fruit. Drugs are hard.